Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a cataract with grade 3 nuclear sclerosis. Let us observe this surgery. Two side ports are made, one at 9 o'clock, another at 2 o'clock. And now, 2% hydroxypropyl methyl cellulose is injected into the anterior chamber. The antechamber is filled up with 2% HPMC. And now, a 2.8 mm main incision is made at 11:30 o'clock. Capsular access is to be done now. A capsular tag is raised with a needle, and then I use a uterata forceps. Hold this tag, go anti-clockwise all around, and do a continuous curvilinear capsular access. Capsular access is done. Now hydrodissection is to be done. This is hydrodissection and this is hydrodelineation. Hydrodelineation was attempted, but it was not good. The nucleus is rotated. Visco is again injected, and now is the time to introduce the tip of the phaco needle. This is a totally unedited recording of the surgery. The tip goes into the anterior chamber, bevel down. Some superficial cortical lens matter is aspirated. The handpiece is turned, bevel is up, and now this is direct chop. I bury the tip into the substance of the nucleus, hold the nucleus very firmly, and then chop it. The nucleus is being divided into 4 large fragments, and then each fragment is emulsified and eaten up. Since this is a soft cataract, the nuclear fragments can be eaten up without dividing them into smaller pieces. And this is an instrument, I call it PCP, posterior capsule protector. The epinucleus and the last piece are emulsified when this instrument protects the posterior capsule. And in this case, I attempted to remove some cortex by the phaco needle itself, but I was too scared to do it. So I inject visco again and use a 23 gauge Simcoe cannula to remove the cortex. Yes, the cortical matter are coming out very easily. Yes, the cortex is removed, and now I take the irrigating probe and the irrigating fluid. The fluid jet is swept over the posterior capsule, and thus the posterior capsule gets polished. I call it hydro polish, and this is known as hydro implantation. The antechamber is kept formed by the irrigating fluid, and the lens is implanted in the capsular bag. The advantage is visco-induced intraocular pressure rise will not occur with this technique. And now this is moxifloxacin. The side ports are closed, and now we'll see there is lot of visco sticking to the back of the cornea. We're going to remove that by a Simcoe cannula. As we inject fluid, this lot of visco which was sticking to the corneal endothelium has come out. So this ensures 100% removal of viscoelastic substance, and visco-induced raised intraocular pressure will not occur if we do this final lavage. The incidence of TAS, that is toxic anterior segment syndrome, is much less if we conclude the case with a final lavage. The integrity of the wounds are checked, few drops of moxie is applied, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.